That's better. Okay, this subject of mechanotransduction has made me think for a number of years. And I previously lectured to the BSSH in Dublin on this subject. And this is an update on the thoughts I had at that time. So this is my present role working in Singapore. We are machines. And here's a wonderful illustration, classic illustration by Leonardo da Vinci, who actually was an anatomist before he became an artist. And he has shown beautifully the machinations in the human hand. We've evolved in response to gravity. And here is Charles Bell, who was the first professor of surgery in London and wrote this wonderful Bridgewater treatise on the hand, its vital endowments. And he had many insights into the human hand. He said that the magnitude of the earth determines the strength of our bones, power of our muscles, and the atmosphere must determine the condition of our fluids. So he had this idea that we were products of evolution and influenced entirely by outside forces. I'll come back to that at the end. So what is mechanotransduction? Well, here are a few lazy cells sitting on top of a piece of 3O-proline. And mechanotransduction is the influence of physical forces on these cells, resulting in cell activities such as movement or division, or it may make the cells produce all sorts of materials, matrix materials, growth factor cytokines, or the physical force may even provoke apoptosis or necrosis. And here's a definition from the journal Nature, so it has caught the eye of fairly high science, that this is that physical forces have some part to play in what we are and in the diseases that afflict us. So in short, our cells respond to mechanical forces, especially fibroblasts. You see this in repair. You also see it in cancer and embryology. And it must be understood if we're going to do tissue engineering. I think that as hand surgeons, we have an intuitive understanding of forces when we're repairing a patient. And what we need to think more about is the science. So this is where my scientific endeavor started in London, University College, working with a number of people, including Eric Valbeam, who I saw in the audience. And this was our first experiment. And the pink gel here is a collagen gel in which we've populated a huge number of fibroblasts. And this simple little device has an anchor on one side of the red gel and a strain gauge on the other side. And the strain gauge is measuring the contraction of the gel. And it gives us a picture of the contraction like this, where the fibroblasts contract the gel very quickly over about 6 hours. And then we have a rather withering plateau after that. But this has given us a way of understanding how cells interact with collagen, but also it's a way of measuring the force of contraction. And Mark Eastwood, who is the first author on this paper, this was his PhD. And when he told us in a pub one night that he could measure the force of a single contractile fibroblast, we knew that he'd been imbibing too much, and this must be impossible, but he did it. And effectively, here is the force of the contraction of a single fibroblast. If we think about a Newton as being the equivalent of an apple falling on your head, the force of the fibroblast is 10 to the minus 10 of these. And he did this by putting a known number of cells into the gel and then dividing it by this known number. He then modified this device here and mounted it on a microscope stage, which was repurposed with a stepper motor. And this allowed him to stretch the gel or allow it to contract. So here we are. Here's same curve again, only now once we get to the top, to the plateau, he's allowing he's using this device to stretch the cells, the gel, or to allow it to relax. So the withering plateau is still there. Let's look at it in a magnified screen here, and we can see these wavy lines better at magnification. And what you'll see is that there's the plateau again. And as you relax the gel, the graph, the curve drops down to the bottom, and then you switch it off and it will start creeping up back towards this red plateau again. Or if you increase the tension on the fibroblasts, they will then start to reduce it. And they do this by changing the matrix round about themselves. So there is this tendency for the cells to want to have a particular level of tension. They're just like students, really. If you give them too much tension, they'll try and reduce it. And you give them too little and they'll create some new tension and increase it. So this is the way fibroblasts work. And we call this, in fact, I coined this term of tensional homeostasis, which tells us quite a bit about the way our body is structured. So let's look at the gel in a bit more detail. If we pull a gel out to length here, and then look at the cells in the middle, they're well-aligned cells. They line up their internal proteins in the line of force, the line of tension. If you pull the gel crossways rather than length to length, get a different aspect ratio, much more complex forces acting in this area that's magnified here, and the cell gets pulled in many directions, so it becomes stellate. So our very cells are responsive to mechanical force. Here's another gel where we're pulling our gel from side to side and putting into it, these three black columns are actually strands of matrix on which we've populated cells. So by stretching the gel, the cells are going transversely, horizontally, and by sticking in these filaments of cells at right angles to that, we get the right-angled cells appearing here just about. And what they do is they turn through 90 degrees. So they line up their line of orientation along the line of stress. And we'll come back to that when we get to some clinical applications. So cells align with the direction of force. Not only their internal proteins are aligned, but anything they make on the outside gets aligned. So this is a reconstructed fibroblast here using an MRI type 3D reconstruction technique in miniature. And the white strands here are collagen, type 1 collagen, and they're lining up along longitudinally along the line of force. Now, it's been known for a long time that hard tissues conform to physical forces. There was this magnificent book on growth and form by a gentleman called Darcy Wentworth Thompson. And with such a name, he was bound to become an eccentric, which indeed he was. But he told us quite a lot about forces in bone. And many people have taken up this this concept, thinking about the trabecular pattern being a map of strain lines. And we've all seen this picture of the head of the femur. It's the one that's always used to illustrate Wolff's law. But it happens in the hand as well. Here is a hand. It's actually a histological slide. And the hand, you may have difficulty recognizing the joint here. It's actually from an extinct primate. I think it was a type of chimpanzee. But I show this to point out that actually other people, other than surgeons, have taken much more interest in this internal anatomy of the bones. We've been terribly slow to get interested in this. If you look at this primate bone, you'll see it's got a great thick cortex in the shaft of the bone, but the cortex almost disappears when you get to the bone area. It's all trabecular bone. And people have written theses in anthropology on what this primate was doing on the basis of his bone structure. And we just glance at x-rays. The one person who's really thought carefully about the internal anatomy of bone is Greg Bain from Adelaide, and his group all been involved in this. And here is one of his diagrams of the lower end of radius, a bone which I understand is frequently shattered. And again, you see that it's got a reasonably thick cortex, but it thins right out as you get near the joint. It's all trabeculations there. And here's a human hand, and you can see at the head of the P1, there's longitudinal trabecula showing that there's longitudinal stress. And the base of the P2, it's not the best picture of this actually, but anyway, it shows that the trabeculations are going in various different directions. And so this bone is very soft and very crushable. And we are impudent enough to try and stick screws in this and get them to hold. There's almost no cortex to hold when you get near a joint. And here's a fracture. The trabecula tell you how your bone's going to break. We need to do more work on this. So that's bone. Bone's easy. I didn't want to spend too much time on bone tonight, this morning, whatever. Let's think a little bit more about the soft tissues, because it's much more understand the role of forces in soft tissue anatomy, physiology, or repair. And we'll show a few examples. I'll talk a bit about wounds and scars, contractures, with tendon healing, trigger finger, fascia. And here we are with wounds and scars. Let me apologize at this point. I'm going to show a few other pieces of anatomy. I know you're all hand surgeons, but the same thing happens to the hand. I just happen to have these slides. So I started off thinking, is there a critical depth when you injure skin where it scars? You know, you get an abrasion in the back of your hand and you hope that that it won't scar. And why does it scar sometimes and not other times? And it's all to do with the depth of injury. And here's a case that shows the problem. This is a young man who broke into a tattoo artist with his friends. And unfortunately, they didn't take with them a copy of the Oxford English Dictionary. And his ace of spades is SPADS. Now, I offered to put an E in here, but he wanted his tattoo removed. So we dermabrated his face. We ground it down with a grinding disc. And bits of it have healed nicely and bits of it are scarred. And why did that happen? And this was the patient who started me thinking about this problem many years ago. Nowadays, you take this off with a laser. Anyway, what happened was the bits that have gone deeper have left a scar, and the scar grows and hypertrophies as scars do. And as scars do, it eventually goes flat and mature. And so this was the final result. At this point, he was able to get a job and fathered a child, brought the child in and sat him on my desk to show that he was now a human being. I mean, the father, not the son. So the depth of injury is important. So I devised this experiment to look at the depth of injury. What we're doing here is we're going to stab people with this device. It's a steel plate that tapers, thin at one end, thick at the other, a little runner that holds a scalpel blade. So you can stick this on somebody's anatomy and slide along, and you get a wound that's deep at one end and shallow at the other. It looks rather like this. That's a bit of pig skin. We didn't go quite that deep in people. We did 110 volunteers here, not all of whom worked for me. And it produced a wound of varying depth. And here's a typical result. We did this in unsightly places like the hip. And you can see at the top left that just immediately after it's done, the wound is deeper and wider at one end and shallower at the other. And then as the weeks go on, the scar becomes less and less, it becomes shorter and shorter. And so the superficial bit has healed without a scar, and the deep bit has left a scar. And that critical depth on this site in the body had an average of about 0.5 millimeter. So the depth of the scar, depth of injury will determine whether the skin scars or not. And that's partly due to mechanical deformation of the skin. It's also due to different cell populations. It's a mixed thing, but it does show that there's a mechanical effect in wound healing. So here's another mechanical effect in wound healing. We're going to make wounds with a round punch right down the middle of a human being. And this is, of course, a cadaver. And one great advantage of this particular experiment was at the end, we could cut the whole strip out and then leave it to the pathologist. And when the patient was stitched up, we couldn't see anything of our experiment. This was allowed under law at the time we did it. It wouldn't be now. Anyway, made round punches right down the patient. And in the chest, the round hole got wider and taller. It stretched in 2 dimensions, whereas in the abdomen, it just stretched transversely. And this tells you what the scar is going to look like. With a 2-way stretch, you're going to get a keloid. With a 1-way stretch, you'll get a stretched scar. And this is an abdominal wound. It doesn't show up terribly well in this lighting here. I hope it's better on your screens. But just opposite the umbilicus there, there's a very stretched bit of scar transversely. And here's a lady with a scar. It's always worse in the females as well, because there are so many different forces acting on the scar. You tend to get a poor scar in this midline area. I didn't have a good picture of the hand, and earlier on, when you were all at work, I just photographed my own arm. So if I can show my arm, where is it? I can just about see there's I can't show it on the screen. Anyway, there is I drew a round circle. Try it on yourself, or your wife, or your boyfriend, or a patient. There are certain areas of the body where if you draw a circle and then move it, so slide 2 here is me bending my elbow, and Langer's lines look as though they go transversely. Langer made a great mistake, Karl Langer, in that he described his lines on cadavers. He used a round punch and punched the cadaver all over and then took pictures or drew drawings of the orientation of the scar. But a cadaver is only going to deform in one direction. Whereas when I straighten my elbow here, my Langer's lines are rotated through 90 degrees. And that's what happens. So if you look at the areas of the skin and you're working out how to get a good scar, then get the patient to move, draw a circle in the skin and get them to move. And you'll see which is the dominant line of tension. And if circle stretches in two different directions at right angles to one another, you are going to get a terrible scar. So lo and behold, do this on your knee or on your shoulder, and you'll see why people get a terrible scar. It's very important to have this knowledge to blame the patient's biology and anatomy for the scar and not your technical expertise. Here is a very extreme example of scar stretching. And this was done by somebody who wanted to make the scars obvious. I'm sure a pop star will get this done and it will catch on around the nation. There might even be some private practice in inflicting these or treating them, but nevertheless, what you see here is that all these scars are stretching in rather different directions because of the different tension of the skin. So skin mechanics determines the fate of your scar. So how can you get around this if you want a good scar? Well, you want to stress shield the wound. And you do it internally by burying stitches and using a subcuticular stitch in the dermis. It's the scar being revised, an abdominal one, with a subcuticular stitch. And then external splintage by skin tapes. Now, for some reason that eludes me completely is you should never use skin tapes, the 3M ones, in the length that they provide them to you. If you put on a full length tape, it will blister the patient at both ends because there's such a different modulus of elasticity between their tape and the patient's skin. So use short lengths of tape and have them touching, or else if you leave gaps between them, which is what 3M tell you to do, you'll end up with getting tension, compression, tension, compression the whole way along the wound. Every fibroblast will be confused about the map of forces and you'll get a worse scar. So short tapes, edge to edge. Right. Even keloids are influenced by mechanical forces. Here's a nice shoulder keloid, started off as a vaccination scar, which was almost nothing, and it's stretching in the lines of dominant tension. Okay, enough on keloids. Okay, let's come to our second area of tension. Surprise, surprise, I'm going to say a little bit about Dupuytren's contracture, but not too much. Dupuytren's contracture occurs in certain longitudinal lines, although there are fascial planes transversely and vertically as well. This is a map of them. This is a map magnified here. And essentially, each of these lines of fascia is actually a map of the tension that's been applied all the way from intrauterine up to the present time. And in some way, tension is involved in Dupuytren's disease. Exactly why it happens to some people and others, we're still not sure. There's certainly a set of gene mutations that have been elegantly mapped out. But it's the longitudinal tension, longitudinally out with the movement of the hand that keeps stimulating the whole thing. I think it starts as a an adhesion between these transverse, longitudinal, and vertical fibers, and then you keep pulling on the adhesion. And in a way, when we grew Dupuytren cells in our tension monitor, we found that they behave rather differently from skin fibroblasts. They keep on contracting. So there's something different about the cells. So we know that Dupuytren's tissue contracts. Well, we know that the cells are contracting. So is it the tissue that contracts or the cells? What is it? And we grew bits of Dupuytren's tissue in these vertical glass cylinders here, stained red for easy identification. And what we found is if we stretched this Dupuytren's tissue, it expressed what we used to call collagenases, matrix metalloproteinase 2 and 9. So you can stretch Dupuytren's tissue by getting it to express, by pulling on it too hard, harder than the cells like with their tensional homeostasis. And the cells will express collagenase and remodel the scar. So we can use that clinically. So here's a clinical application using these little mini Pennig fixators. You can stretch out a Dupuytren's contracture of a joint. You put 2 of them in to get a better grip of the bone and use rubber bands between the 2 sets of pins. And rubber bands put a stretch on the tissue. You can't use a rigid fixator for this. It's got to be stretched all the time. But the patient must be able to overcome that stretch. The bands mustn't be too tight. I had one chap who decided he would straighten his contracture in a week, which he did. He was a mechanical engineer. He kept putting on more and more bands, but he ended up with an arthritic joint, which, thank God, 25 years on, is still not painful. I know him quite well. But he does have a rather interesting joint on an X-ray. Anyway, this is another patient showing up here, but it shows this is one in whom we've stretched out the PIP joint. And then as a second stage, put some local anesthetic in, put in a small skin graft, and it will stay like that. The finger will stay straight. This technique was shown by Carlos Messina in Italy. And we'd modified it just to pull on one joint. He pulled on everything with a great big X-fix. Okay, that's all I'm going to say about Dupuytren's. You're probably fed up hearing me talking about Dupuytren's. Let's go on to tendon healing. This is a beautiful experiment done in Aberdeen many years ago, where the anatomist who did this cut a window in a tendon to see if it healed. And the left slide is control of an intact tendon, and it shows lots of type 1 collagen and quite big fibroblasts. The middle one, he loaded the tendon by having the animal run around for a long time. And what's happened is initially, it's not that tendon fills in the gap. What actually happens is the 2 edges of the window, the 2 bits of the window frame hypertrophy. They lay down lots more type 1 collagen. Initially, they have tiny fibers with lots of type 3 collagen as well as type 1. And the 2 windows actually have an increase in the type 1 collagen. A dedicated research student spent countless hours counting these collagen fibers. And sorry, I have pressed the button too fast. Let me just go back one and finish that little story. Previous. It's gone. Anyway, what I was going to say is that very slowly the window starts off cartilaginous because it's under compression as the tendon grows, but eventually it will turn into tendon. If it's unloaded, it will maybe never turn into tendon. And this happens in a lot of tendons that degenerate, like forelimbs in horses and certain tendons around the shoulder. However, here's our next experiment in tendon healing. What I wanted was a fairly clean experiment, and Jason Wong did this wonderful work. And this was a clean experiment. We took a tendon in an animal and just tied a knot in it, because this is a component of so many different types of repair. And this is the histology in the middle, and there are no cells round about this stitch. The cells have all disappeared. Where did they go? Initially, we thought they disappear. They just move aside, and some of them do. The ones at the margin do, but the ones underneath the stitch die. And they die because there's a very high strain in the tendon, as shown by the bottom multicolored drawing. So when you stitch a tendon, these are the components of your repair. You're bound to kill off a certain amount of tendon, I regret to say. Now, Jason did a lot of nice experiments. Top left's a control. Bottom left, this was a partial cut in a tendon with huge amount of cellularity in an adhesion. And bottom right is 6 months later. The adhesion is still there because the original adhesion had fibroblasts migrating into it. And now we have a fibroblastic adhesion. So the fibroblasts follow lines of tension. So probably the more physiotherapy you do on this, the more adhesions you may be getting. On the other hand, if your physiotherapist pulls really hard, the adhesions will express collagenase and you may get rid of them. We really don't quite know the science of the sequence of that, but that seems to be the way it works. This is a tendon repair done in a mouse by Jason. Wow, imagine being able to repair a mouse flexor tendon. Well, he did it. And the dark areas here are areas of cell death in the middle illustration. The red lines are the actual tendon. And so you can see that not only where the stitch is lying, but in areas where the stitch has produced a high tensional load extending along the tendon, there is cell death. It's amazing how tendon repairs ever work. And perhaps not surprising that they only work ever 80% of the time. We started off looking at the surface of the flexor tendon, and I have tried to get more grants to look at this, and it needs a lot more looked at. But the surface of the flexor tendon has got keratin proteins in it, and they're normally in skin. And I think it shows that the tendon is under, it has a sort of abrasion process. It has a shearing strain when it produces these keratins to resist the shearing stress. Enough on that. So let's now look at trigger finger, which is scientifically a fascinating condition. It has all sorts of other names like stenosing tenovaginitis, because nobody understands it, how it happens. It's incredibly common in Singapore. It's epidemic proportions. And the usual sort of explanation that surgeons like the ASSH give to their patient is, oh, there's a lump that triggers in the tendon, which is almost right. what happens in the trigger finger has been shown by a beautiful series of experiments done by a surgeon called Michael Flint, who's no longer with us, I'm afraid. He did this long before genes came into common conversation. He did this in the 50s and 60s on rabbits. This isn't one of the experiments, it's just a diagram. It's a rather gross incision. If it was an experiment, it's simply a diagram of a rabbit's anatomy. And what he did was he looked at the tendons going around the malleolus of the rabbit at the ankle. And these are his original 4 diagrams. Now, top left, he's showing all the tendons going around a bony prominence. And there's pressure from the bony prominence on the tendons. Bottom left, he's released all the tendons, allow them to bowstring bar 1. So all the force, lateral force of going around the bone is being pressed on a single tendon. Bottom right, he's taken all the tendons away and just left this poor single tendon. And at the point B on both of these bottom diagrams, the tendon turns into cartilage. And if you keep it going, it'll turn into bone. So lateral pressure on a tendon completely changes its force map, and the cells do something different. They start laying down chondroid matrix, and the tendon becomes cartilaginous. There are lots of bits of our tendons that do this and keep surgeons busy. Top right, he's released all the tendons, including the one with the B area, and the tendon goes back to normal tensional tendon. So this is a reversible but very definite process. So you push laterally on a tendon, it becomes cartilaginous. So where does that fit into trigger finger? Well, is the primary problem the pulley at all? The pulley certainly shows chondroid metaplasia because it's being pressed on. And this was, I think, first described elegantly by Larry Hurst in Long Island, who's the originator of collagenase. But this is a few years ago. He and Marie Badalamenti did this nice histology slide and showed that there's normal A1 pulley, and there's pulley from a patient with trigger finger. Lots of people had looked at bits of tendon sheath before this and shown the chondroid metaplasia, but they described it very elegantly. But very few people, in fact, only 2 I've identified so far, have had the courage to biopsy the tendon. And a Swedish lady called Ann-Karin London did a beautiful study on this, looking at genetics and histology. And what she showed was that essentially the tendon is abnormal. It looks like Achilles tendinosus. So there are kind of a couple of possibilities here. We're not quite sure exactly what tendinosus is. It's described differently by different pathologists. The Mayo Clinic thought that the tenosynovitis problem in the tendon may be due to a lack of lubrication, due to a molecule called lubricin that sits on the surface of the tendon. And that may actually be the start of the whole trigger finger. It may well be a degradation of the synovial surface of the tendon that starts it all up. We did this study. It was done beautifully by Shilling Zhang, who is now one of our trainees. And she did this lovely study on trigger finger with ultrasound, measuring the tendons. And this is a histology slide, of course. And she measured the tendons at various fixed points, like halfway along the P1 and 0.25%, etc. And then these are some of our histology slides here. All these different measurement points were numbered. And what she found was that in 0.4, the blue column, which is the normal side, she found patients with a trigger finger on one side and a normal finger on the other side. So the tendon was at 0.4 was in a normal tendon was thicker than the rest of the tendon. But with a trigger finger, it became even thicker. So at this point here, a quarter of the way along P1, the tendon is thicker. Why is it thicker? Well, here's a dissection that explains it. In full extension, top slide, this is the thickest part of the tendon, and it's where the sublimus has just split, just about to split, and where it's starting to wrap round the profundus. There's a thickening in the combined tendon mass. I've moved windows out of all the pulleys here. You'll get confused about what's A1 and A2. And then mid-flexion, it moves proximally. Near full flexion, you can't actually ultrasound somebody in full flexion. The probes would need to be paper thin. But this moves forward and it jams in the A1 pulley. So this thickened tendon jams in A1. So here's a summary of what happens in a trigger finger. The whole tendon in no man's land is thickened in the thick finger. There is a normal anatomical wide part where the FDS grips the FDP. As you flex your finger, the thickened area moves proximally, and triggering occurs when this FDS bifurcation crosses the A1 pulley in the thickened tendon. So the tendon is thick, is thick, as well as the A1 pulley. Why? Well, I'm not sure. I think it probably dries out. And I think it dries out because of degradation, an age-related degradation of the synovial covering on the tendon. You get trigger finger at 50 plus or minus. You can get it in younger people if they're crazy enough to pump iron every night or get a job counting banknotes or something like that. But it normally settles and heals pretty quickly. But the trigger fingers in older people tend not to. You're better to operate on them, I think. So both tendon and pulley are pathological. The fifth area I thought I'd talk about a little was fascia. And this is the subject that I spoke about previously at the BSSH. So this is a potted version. So what determines the various types of fascia? There's all sorts of things in the body that are collagenous that we call fascia, and they don't look anything like one another. Like, for example, your transverse retinacular ligament across you're doing a trigger finger, a carpal tunnel operation. As you go down through the layers, you go through the longitudinal palmar fascia, if the patient's got one, and then you come to this transverse thick structure, which is causing your median nerve compression, and they all look very different. So what determines the various types of fascia? Is it genes, or are the laws of physics important? Oh, I went back, sorry. And when you begin to look at maths and science and the laws of physics, you begin to see things like if you bend a steel bar, it has strain lines in the direction shown. And that looks a bit like the hand in Dupuytren's contracture. So strain seems to be important in the design of fascia. If you write back and look at the fetal development, this is the embryology of the carpal tunnel. And you can see that a lot of longitudinal structures are appearing now. It's a transverse cut. And these are the tendons. There aren't 8 tendons there yet. It starts off with a much smaller number, and then they begin to divide side by side. On top of that, you've got around about it all, you've got mesoderm. The top layer will form the dermis of the skin, and the bottom layer will form the periosteum. So if the whole thing is the development of our body conducted by mechanical laws, not just genes. Genes make a cell produce proteins. They don't produce shape and structure. So the organized bits of fascia conform to Newton's laws. In other words, you pull on a bit of fascia and it will tend to get stronger. This happens with things like Achilles tendon. We had a hockey match between Glasgow and Edinburgh, and I heard that the score was 3-2 for the Edinburgh people. And I thought, that's a funny score for hockey. And yeah, 3 Achilles tendon ruptures in the Edinburgh team and 2 in the Glasgow team. So if you rush out and start exercising yourself too quickly, you're going to probably acutely produce matrix metalloproteinase and not strengthen your tendon. But effectively, Newton's laws of effectively equal and opposite forces determine a lot of what we call fascia. But there's also gliding fascia. And where does this come from? What are the laws that control this? These are, of course, the fabulous dissections of Jean-Claude Gimbertot, who has produced books which you should all read, and quite fascinating. I think the nearest simile to the Gimbertot fascia is a soap bubble. And this is controlled by the laws of plateau, which apply to foams. Soap bubbles are round until they come together, and then they become flat-sided. And they join together at little triangles you can see in the middle of this called a plateau border, in celebration of Joseph Plateau, who described this well over 100 years ago. And these 3 bubbles meeting together and meet at an angle of 120 degrees. And where the various lines cross in the soap bubble, you get what he calls a tetrahedral angle. Now, if you get such a thing as a perfect bubble, that's where the amount of soap, the surface area of all the soap is optimized to contain the largest area, the largest volume of air. And this is a question of a perfect foam has been argued about by great minds for over 100 years, and the argument's still going on. But the one in common parlance at the moment is you have 6 of this shape, 2 of that shape, and you put them together. And this will give you the smallest surface area you need to contain a given volume. We call it the perfect foam. And architects have copied this, not least in China, where they wanted to use the minimum amount of material to build the swimming pool, which became, of course, the curling pool at the Winter Olympics. But effectively, this building is made with the minimum amount of material possible by copying the mathematics of this Weir and Whelan's law. So how can we get a better understanding of all this mechanotransduction stuff? Can you really measure the contractile force of a single fibroblast? Or can you even measure what forces different parts of the fibroblast are measuring? Yes. We start off by nano creating a pillow of polymer pillars. Here we are. Tiny ones, less than a micron. And then you sit your fibroblast on top of this, and the fibroblast will pull on these pillars in multiple directions. It's not just moving in one direction, it's exerting force in multiple directions. And by looking at the electrical deformation, because these pillars are all electric conductive, by measuring the deformation of a single pillar, you can calibrate how much force it's exerting at a particular point in its circumference. This has all been done in mechanobiology lab in Singapore. I just visited them. It's not my work. They kindly lent me these slides. And so you can think about a fibroblast as being a bit like an Indian fakir, being balanced on a whole lot of little columns, but unlike the fakir whose columns don't deform, these ones do, and they can tell you a tremendous amount about the way cells migrate. And just one or two other very brief diagrams. This one top left here shows a group of cells that are advancing across a surface, a bit like epithelialization of a burn. And on the right, they're looking at a single column of cells. And when the whole group of cells move forward, then they are exerting an equal and opposite force on the surface that they're gripping, whereas with the single column of cells, they can't pull strongly enough, so the forces are going in different directions, so the cells all line up. And these are the sort of formations we've all seen in histology slides, that cell movement and cell motion seems to be under laws of physics and mathematics. So to complete the circle, Charles Bell thought that we were the product of external forces, and he's right. But we're also the product of internal forces created by our own cells. And this is, of course, you'll immediately recognize this is a zebrafish. And you will all know, I'm sure, that a zebrafish grows by all the cells multiplying in its tail. That's on the right-hand side of this zebrafish here. And as the cells proliferate in the tail, because of they're all trapped underneath the ectodermal layer, there's a longitudinal force runs right along through all the myotomes. And within each of the myotomes, the muscle fibers all run longitudinally, as you can see at the 12 o'clock position. So we're not just products of external forces, gravity, atmospheric pressure. We're the product, and our diseases are the product of many internal forces and activities that can be characterized by laws of physics and mathematics. The perfect foam, is it possible? Yes, this is in a cup of coffee. How do we recreate a perfect gliding foam in our patients and not get fibrous adhesions? Food for thought. Thank you for listening.